Good morning. Good afternoon. Welcome to today's presentation, New Frontiers on RSV Infant Disease Prevention, what organizations need to know to ensure equitable access for newcomer children. Before we begin our presentation today, we would like to begin with an acknowledgement that N4 is hosted at CHIO, which is located in Ottawa, Ontario. Ottawa is built on unceded Algonquin and Anishinaabe territory. The peoples of the Algonquin and Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. We also honor all First Nations, Inuit, and Métis peoples and their valuable past and present contributions to this land. My name is Colleen Drake. I am N4's Project Engagement Coordinator. I will be hosting and moderating today's presentation with my colleague and co-host, Yusuf Khalil, N4's Communication Specialist, who will be monitoring the Q&A box today. I am now pleased to introduce you to today's presenter. I am going to ask that you turn on your video as I introduce you. Dr. Eliana Castillo is an obstetric, internal medicine, and reproductive infectious diseases physician at the University of Calgary. Her research aims to spend and scale preventative strategies that protect mothers, babies, like vaccination using implementation sciences and patient-oriented research methods. Welcome, Dr. Castillo. Today's session is being recorded and will be uploaded to N4's platform. We will share this with you as soon as it becomes available. Should there be any technical issues during this presentation, we will inform you with details for an alternate makeup session. Before we begin today's event, I would like to take a moment to introduce you to our platform features to help enhance your participation experience. Throughout today's session, we invite you to write your questions in the Q&A window. We know that sometimes many of you might have the same questions or be interested in a particular response. Today, you have the option of upvoting a question. Please upvote questions you're interested in hearing the answer to, and we will prioritize which questions we pose to the speakers first. N4 is pleased to announce that select webinars are now accredited. Accreditation is pending for today's webinar. Our 2025 series is currently under review, and we will be pleased to let you know when this is in place. Members of the Royal College of Physicians and Surgeons of Canada, the Canadian College of Health Leaders, and the Canadian Psychological Association earn credits towards their maintenance of certification requirements by attending select N4 webinars like today's. With that said, let's jump right into today's presentation, and I will pass the virtual podium over to our presenter to take it away. Over to you, Dr. Castillo. Thank you.
Very good. Thank you, Colleen, and good afternoon, everyone. Thank you very much for inviting me. As Colleen said, I am a physician. I work out of the University of Calgary, and for about 25 years, I have been working with people who is pregnant and they have a medical problem or they have an infection. I have several disclosures. So basically, I have funding for some of the work I do for research from the Canadian, from CIHR, from the Public Health Agency of Canada. I also advise at the National Advisory Committee for Immunization, and I have also received funding from industry. So I would like to acknowledge that I am presenting from Calgary. But more than that, I would like to acknowledge all the lands, all the rivers, all the waters where we have the privilege to live and to work in Canada. And for those of you who are in Ottawa and and for those of you who have had the opportunity to visit the Museum of Civilization, this is a beautiful painting that is at the dome of the Museum of Civilization by an amazing artist called Alex Jambier, who died last year and is. And where are you joining us from?
So I've launched the first poll, Dr. Castillo, and the answers are
Thank you.
coming in. So we'll give everyone a few moments just to respond, and thank you, attendees. Looks like we have a lot coming in from healthcare. We've got some academia, education. Oh, and we've got a few other. So we're about 65% participating. So if that gives you an idea of where we're at, Dr. Castillo, I can
This is
end the
very good.
poll.
Yep, this is good.
Wonderful. And I'll share the results with the audience.
Okay, so mostly healthcare and academia and education. Very good. And just the other simple question is, where are you joining us from today?
Pop that one up on the screen. We've got some responses coming in from across the country. So we have a lot in British Columbia today, some in Alberta, Manitoba, Nova Scotia, Ontario, and we'll just give it a few more minutes, Dr. Castillo, for the attendees to respond, and then I'll end the poll and we can share those results.
Very good.
So we're at 81%. That should give you a pretty
Yeah,
good
should give us
idea.
a good idea.
Perfect. There we go. Sharing the results.
Okay, great. And this is relevant because what we're going to discuss today, and actually what is accessible for mothers and babies across Canada, is different. So, so anyway, this will be very good for the discussion. So I'm just going to going to presenter mode again, and this is something that someone else said. It's not my concept, but I really wish to remind that vaccinations, the ones that actually goes into people's arms or sometimes in the little thighs of little babies, vaccinations save life. But vaccines sitting in a fridge do not save lives. So there is a lot that we need to do, especially in our world today, to hopefully support moms and babies and their families so they can get the benefits from available vaccinations. So today we will be talking about RSV, which stands for Respiratory Syncytial Virus. So the virus is an RNA virus. We have known about this virus for a very long time, and actually we have been trying to make vaccines about for this virus probably since 1950, and it's not until more or less a year and a half ago we were able to finally get a very good vaccine against this virus and a very good monoclonal antibody, which is part of what we're going to be talking about today. This virus has, and probably all of you are used to this with the coronavirus, has all these proteins on its capsid, and these proteins allow us to make products against the virus. So the most important protein that allowed us to make a vaccine and a monoclonal antibody against this virus is the fusion protein that is depicted right here. This virus is, and actually humans are the only reservoirs from this virus. So our dogs and our cats do not get RSV, and is transmitted by droplets and by contact. And by droplets is exactly like in the picture says, when we get RSV, we sneeze, and those little particles travel and can get to other human beings around us. And as well, when we sneeze and we have RSV, those little droplets can travel and can infect surfaces around us. And that's what we call indirect infection. Going back to that first statement of vaccines do not save lives, but vaccinations do. I just want to take a couple moments, especially knowing that a big proportion of the attendees are healthcare workers, to share with you something that you probably know, but I think it's important to remind, and it is the fact that pregnant individuals and their babies have always been and will always be at increased risk from morbidity and mortality from infectious diseases. And why is that? When pregnancy is an amazing phenomena, it's amazing what Mother Nature does to allow a human to carry another human for 9 months without attacking that human because it's another person. But those changes that allow a human to get pregnant also make that human more susceptible to the effects of infection. So when a person is pregnant, they have far more blood. And those of you that have been pregnant, you know that you get very swollen. When a person is pregnant, is breathing for two, is pumping blood for two. So the cardiovascular and the respiratory systems are under a lot of stress. There is a hypercoagulability during pregnancy that is necessary. So pregnant people, don't bleed to death when they have a baby, but that hypercoagulability also gets exacerbated with infections. The immune system in pregnancy changes in a very interesting way. The first line of defense against pathogens. So, and those things that we have on our body that are meant to stop pathogens, those are upregulated. However, there is a part of the immune system that has to calm down and to tolerate baby. And so I think of the pregnant individual as someone who is always ready to fight. And when they get an infection, it can be very severe because they are in a inflammation pattern all the time. So the evidence has shown us consistently that pregnant individuals are more likely, if they get a respiratory infection and other infections, they're more likely to go to intensive care unit. When a pregnant individual gets a severe infection like influenza, like COVID, like RSV, like a urinary tract infection, they are at increased risk of preterm birth. And we also know that those little babies are at the highest risk of morbidity and mortality, especially from respiratory infections in the first few months of life. So for example, pertussis, and those of you that are in Ontario probably are aware that there is an increased activity on whooping cough and pertussis, which is very, very severe for babies in those first 2 months of life before they can get their first shot. And the only way to protect babies from whooping cough is for mom to get vaccinated. And we also know that RSV, which is the virus that we're going to be talking specifically today, is very severe, especially in those first 2 months of life. So if a young baby gets RSV in the first 2 months of life, there is a 40% chance that that little baby is going to land in the hospital. So going back to RSV, it's a very common virus. 70% of babies get RSV in the first year of life, and almost all kids will have had this virus by the time they are 2 years old. Like all viruses, well, like most respiratory viruses, RSV can cause an upper respiratory infection and a lower respiratory infection. We very much worry, especially in babies and in older adults, when that virus that starts as an upper respiratory infection progresses to a lower respiratory infection where the lungs are affected. So if we look at babies that will have bronchitis or bronchiolitis. So RSV causes about 33 million of lower respiratory tract infections per year worldwide. Is responsible for about 30% of all cases of pneumonia in children, and RSV kills hundreds of thousands of babies worldwide. So it is serious. If we look at Canada, we know that about 10 to 20% of babies who get RSV will need medical attention. About RSV accounts for more than 60% of all babies who are admitted to the hospital for lung or for breathing infections, and about 5% of babies who are admitted to the hospital with RSV will end up going to the intensive care unit. So something very important to understand, and I don't know if I have it here, I missed that slide, is that even though RSV can be very, very severe for babies who are premature, when we look at all babies, all young children who get in the hospital with RSV, the majority are actually healthy babies. And the reason is because RSV is very, very common. So even though it can be very severe for premature babies, babies who are born with congenital heart disease or babies who are born with lung disease, the majority of babies who end up getting sick and hospitalized with RSV are totally healthy, full-term babies. And in Canada, RSV is seasonal, or in Canada, in the United States, in the Northern Hemisphere, RSV is seasonal, and as influenza, it see a peak during the respiratory season between October and March, when it gets cold and we are inside and closer to each other. And of course, during the lockdowns that we had in the recent pandemic, when we were just not spending time together, especially during the winter, and when we were all wearing masks, the numbers of RSV came down dramatically. And by 2022, we had a very, very, very severe RSV season, very similar to a very bad one that we're having right now. In terms of RSV in pregnancy, we actually don't have very good data to see how often do pregnant people get RSV. For some pregnant individuals, it could be just a cold and some sniffles, but there are reports of RSV being very serious as well for pregnant individuals. So those are the bad news, okay? So now we're gonna get into the good news with it's never perfect. So up until 2024, more or less, we had very limited options to prevent RSV infection in young children that, as I had reiterated, are the ones that are higher risk, and among older adults that are the other ones that are very, very sick. In 2024, things changed, and 2 products got approved by Health Canada for, and as well in the US, et cetera, and in Europe, for the prevention of RSV in young children. So the 2 products are a vaccine that we can give to the mom. So it's what we call an active immunization. So the maternal vaccine has a synthetic version of that fusion protein that I had in the first cartoon. And then within 2 weeks of the pregnant individual receiving that shot, she makes antibodies against that fusion vaccine for RSV. And then she passes those antibodies to baby. So when baby comes out, baby has antibodies against RSV and is protected, or at least partially protected. And then we have another product, which is what we call a passive immunization. And this is a shot that is actually a concentrate of antibodies. So this passive immunization has the antibodies that against RSV that have been made synthetically in the lab. And these two ways to actually protecting babies against a disease is not new. So, for example, for hepatitis B, and this is a vaccine, that probably a lot of you have heard working with newcomers. When we know that mom has a chronic hepatitis B infection, when babies are born, those babies will receive the first shot of the hepatitis B vaccine, so baby can start making his or her own antibodies, which will be the active immunization. But we also give babies the hepatitis B immune globulin, which again is a concentrate of antibodies against hepatitis B. So this, this concept of doing active and passive immunization is something that we use for many other diseases. So the maternal vaccine targets the prefusion protein for RSV-A and RSV-B. The monoclonal antibody targets an antigenic site for the RSV virus. So the maternal vaccine is one dose that is approved in Canada for pregnant individuals to get between 32 and 36 weeks of gestational age. And the monoclonal antibody is approved by Health Canada to be given to babies as a one dose intramuscular anytime after birth. So when we compare which option is more effective at protecting babies against RSV, we can see that there is a difference. The concentrate of monoclonal antibodies, so that, the nirsevimab, as I'm going to call it from now on, it prevents up to 80% of those infections that I had mentioned that will require medical attention. It can prevent up to 80% of babies landing in the hospital, and it will prevent most cases of very severe RSV that require getting young infants to the intensive care unit. The maternal vaccine is less effective at decreasing these adverse outcomes compared to the monoclonal antibody. We have, and again, in this slide, I'm showing the efficacy. So this is the data that came from the studies on the randomized controlled trials that were done before these products were licensed. And now that these products have been licensed, we have effectiveness data, which is the real life, how have these products worked in real life as they were rolled out. So the data that I'm showing here is for nirsevimab, and this monoclonal antibody was approved in Spain 1 year before it was approved, more or less, for Health Canada. So during last year's RSV season, this province in Spain, Galicia, had nirsevimab available or the monoclonal antibody available for all of their birth cohort. And we can see that it was like the effectiveness to prevent hospitalization and to prevent admission to ICU and requiring oxygenation was still very similar to the randomized control trials. So I think I'm just going to skip this. So again, comparing both products side by side, the duration of protection from the maternal vaccine, it can protect babies up to 6 months of life, whereas the monoclonal antibody or the shot that is approved for babies, the protection can last up to 12 months. Once a pregnant individual gets the shot, for her to make antibodies and start passing those antibodies to baby, she needs 2 weeks. Whereas if I have a baby today and my baby gets the monoclonal antibody as soon as my baby is born, the monoclonal antibody will start working and protecting baby right away. Both products are very well tolerated. Both on the trials that were done prior to approvals and licensure, there was no, compared to placebo, there was no increased incidence on the systemic adverse events following immunization. For the maternal vaccine, only in low-income countries was there a signal of preterm birth. And in high-income countries, and actually there were pregnant individuals in Canada who were part of the trials or the studies that were done before the vaccine was approved. The frequency of preterm birth in high-income countries like Canada was exactly the same. And basically this number shows that in the studies for the maternal vaccine, about 5% of pregnant individuals who got the vaccine and 5% of pregnant individuals who didn't get the vaccine had a baby born prematurely, and that is babies that were born before 37 weeks. So the proportion is very similar. I should share with you that in Canada, in general, about 8% of babies are born before 37 weeks. So the frequency of preterm birth with the vaccine was lower, even in the vaccinated people, of what we see in all comers in Canada. We don't know exactly why the increase or the difference in preterm birth was seen in the low-income countries and not in the high-income countries. But what we know is that the study happened in Argentina and in South Africa when they were doing it during the Delta COVID season from 2021. And they may have contributed to the difference. So the safety in the real life data, so places that have had the vaccine available, and actually the vaccine was available in the US for mothers. It was well tolerated, so we have safety data from that, and we have safety data mostly from Europe, where nirsevimab was available last season, and there were no adverse signals. So going back to the question of preterm birth for the maternal vaccine, in the US, there was no difference observed in the frequency of preterm birth among pregnant people who received the vaccine. So Canada, this is the first season where we have had the products available to some people in Canada. So the National Advisory Committee for Immunization in the spring of 2024, provided a recommendation for provinces, because remember, like, the federal government assembles this group of experts called the NACI, which is the National Advisory Committee for Immunization. And that committee looks at the evidence and makes recommendations for the provinces and territories about what they should or should not fund. The National Advisory Committee for Immunization recommended that all provinces and territories would establish an universal program for nirsevimab. And they said that the statement from NACI says that a program where provinces and territories fund nirsevimab is preferable than paying for the RSV or for the maternal vaccine. The statement or the recommendation from NACI also says that nirsevimab, if nirsevimab is not an option, so let's say the province or the territory does not provide nirsevimab for all babies, then the RSV vaccination should be offered if there is no expected supply of nirsevimab for infant immunization, or if the pregnant individual plans to decline or will say, I don't want any shot for my baby. So when the option for those provinces where there is no nirsevimab available is for moms or pregnant individuals to get RSV at 32 to 36 weeks. However, there is a cost. The dose, more or less, of nirsevimab, the cost for one dose is about $1,000 for the product itself. The cost for the maternal vaccine is about $300. So for this season, only 2 provinces in Canada were committed to make nirsevimab available to all babies, and those were the provinces of Ontario and Quebec. So they negotiated, so both Ontario and Quebec negotiated with the company that makes nirsevimab, and they secured the supply for at least for the whole birth cohort, or for all those babies that are expected to be born in the 24-25 season and thereafter. The rest of the provinces and territories in Canada do not have nirsevimab available. And given the recommendation from NACI that the maternal vaccine, which is the second option, definitely not as good as the monoclonal antibody, is available in pharmacies across the country. But if the pregnant individual and if the moms happen to know about it, they have to pay out of pocket the cost of $300, which is probably not an option for many, many Canadians, even those who are not newcomers. Some provinces have made exceptions and have said and again, I'm just going to speak for Alberta. So for example, if some provinces and some private or extended medical benefits plan would cover the maternal vaccine, or something like Alberta Works may cover the maternal vaccine. But the reality is that for most moms and babies who are outside of Ontario and Quebec for this season, and very likely for the next season, RSV season, nirsevimab may not be available, and the vaccine would not be available either if you cannot pay for it. So the key message number one is that we have 2 products approved in Canada to decrease the morbidity from RSV, which is sadly very common, very costly. The key message number 2 is that equal access remains work in progress. So I'm just sharing with you some of the work we have done, and I should have said it at the beginning. Vaccines in Pregnancy Canada, which is the QR code that you can see here, is a free, open access, evidence-based website, or digital hub is a elegant name for information specifically on vaccination during pregnancy. Right now, we only have English and French, but this is a place where people can go and learn about vaccination during pregnancy. There is an infographic that compares both products and can be used when people is having conversations about the vaccines. I have to say, it has been designed for mostly healthcare providers. I don't know that it would be that accessible. For healthcare providers to discuss with their patients. I don't know that it would be necessarily that accessible in terms of language for lay people. And but again, this is the QR code, and this is the place where you can download it. So there is a lot of work that the group I work with, that we have put together to work on Vaccines in Pregnancy Canada, but as well in a course for providers to have better conversations about vaccines during pregnancy and vaccination during pregnancy. And the reason we have invested about 5 years of work working on to improve vaccine communication during pregnancy is because we know that some of the vaccine decisions that parents make start before baby is born. Throughout that work we have done, we have had the honor really to work with newcomer communities, with multicultural health brokers based in Edmonton. And we have had the opportunity to do a fair amount of engagement with newcomers. And I know that the term newcomers is a very big term, and it can mean many different things. What we have learned through our work is that effective communication for vaccines goes far beyond language translation, and that is not only a matter of having things translated to a different language. What we have learned is that a trusted messenger is crucial. So with that, I would like to ask my last question of the audience, and it would be, in your work, in addition to a website like the one hopefully you were able to check or get the QR code, the Vaccines in Pregnancy Canada in English or French, with pictures and information that is put together with patients in mind. What other tools or devices would assist you in your day-to-day when you are having, or when your clients or your patients are asking you questions about vaccines?
And I've launched the poll, Dr. Castillo, so the answers are just coming in. So we'll give the audience a few moments. Looks like there's lots of interest in the live chat, chatbot, self-service portal. Those seem to be the tops. And then we'll end the poll in just a few moments when we've had more responses come in. Thank you. So we're sitting at about 40%. I'll just give a few more moments. I think half of the audience has responded, so thank you for that. And I will end the poll and you'll be able to see the responses.
I am just going to take a picture. This is super important. Please keep it, Colleen, for a moment. Okay. Thank you so much for answering the question. So with that, oops. My computer is misbehaving. I'm just, well, this basically brings me to the end of the presentation, and I really want to have some time for questions, and I'm very sorry about all the technical issues. I'm going to, sorry, I'm not able to stop sharing. It
No
says that my
worries, Dr.
connection is
Castillo.
I'm
Yeah,
so
we
sorry.
can
It says
wait
that my
until it
connection is
pops down.
unstable.
That's okay. If you cut out again, you're welcome to turn off your camera. Sometimes that'll fix the bandwidth, but I can hear you loud and clear right now, and we'll jump into some of the questions from our audience, and we'll just take the first one, and I'll keep an eye on the time. So, what can we do to advocate for the inequity, the lack of coverage for those outside Ontario and Quebec?
That is such a hard question. Because it really depends on the, I think if you're in Alberta, the news are very discouraging. I think, however, it is, well, I should say, in general, there is a lot of will from most basically ministries across the country to secure an ever-growing supply of nirsevimab for next RSV season. Because I think most premiers across Canada have heard loud and clear that there shouldn't be an inequity about what is available for a baby born in Ontario versus a baby born in BC versus a baby born in the Maritimes, or in Nova Scotia or in Newfoundland. So that's number one. I think it is very important that to know or to be aware of what, how can I say, Alberta Works, and again, I'm just talking Alberta Works or AISH, and I just don't know the names of such programs in other provinces would have available, because they can actually make vaccines or medications available for people that don't have coverage. I think there is also a fair amount of work that needs to happen in terms of RSV. We have done a fair amount of work with parents, asking parents about RSV and what they know about RSV. And what we have learned is that when you show the image of a tiny little one with oxygen, it clicks, especially if they were around what was happening 2 years ago. Oh, RSV, yeah, I know, someone happened, that happened. But it's really that image of what we're talking about that makes a difference, not only for providers, but as well for decision makers.
Fantastic. Thank you so much, Eliana. We're really asking you the tough questions today, but we'll do our best, right? And we have quite a few more. I believe I mentioned earlier, if we don't have an opportunity to get to all of our questions today with Dr. Castillo, we will pull those together and get responses to her after our webinar today. And I'll jump into the next question. So I think you touched on this a little bit. What role do community organizations play in promoting awareness of RSV prevention? And I think you've muted. No, you're good.
Yes, I think, listen, as I wish as as a country, as in general, as we would have learned the lessons from COVID. There is no question that during our winter months, during our respiratory season, virus just circulate and jump from human to human. Masks are not perfect. There are a lot of detriments to masks, especially when you're trying to communicate and there is a language barrier. But we were able to make it work in a way during the pandemic. And we were able to wash our hands, right? Remember, just going back to that cartoon about that if I sneeze very close to my computer and then I put my hands on my computer. As humans, we touch our face about 30 times an hour, and we're not aware of it. So the contact and the droplet precautions were not only important for this new thing called COVID, or are not only important for the new thing that is going to come, are important for RSV. And things like, if you are going to visit a new baby and you know that you're sick, maybe your visit can wait a few days. And then the joy of the visit or the joy of the contact, it wouldn't be overshadowed by getting little newborn baby sick or getting grandma or grandpa sick. So I think there is a lot of, as community organizations, that we can do, to remember that even before we had these fancy products that I just discussed today, universal precautions to prevent contact and droplet work. And I really want to remind you, during the 2020-21 respiratory season, not only we didn't see influenza and we didn't see RSV, which meant that a lot of 1-year-olds that were born, babies that were born during that season, they didn't get any exposure to RSV. And then the next year in 2022, the emergency rooms were full. But going back, what we can do, we can still wash our hands, we can still use our common sense, and we can still care. So that's what I would say. And I really encourage people to please go to Vaccines in Pregnancy Canada. Please browse, please send it, please share it with your members. And please send us questions and suggestions for improvement and accessibility.
Wonderful. Thank you so much, Dr. Castillo. And I'm just keeping an eye on the time. So it looks like we have about 5 minutes left. So I'll just wrap up our closing slides. And we do have some more questions that have come in. So audience, we will get those answered. I apologize. We had a few technical difficulties today that ate up some of our time, but we will make sure that those questions are answered. And thank you so much, Dr. Castillo, for your words today. And if you'll bear with me for just one moment, I'll pop up our deck and we'll get that started. And I want to make sure that I leave you a few moments at the end to share your last words of wisdom. So bear with me while I pop this up on the screen. Wonderful. Okay.
Sorry, I was just saying there are wonderful questions. Okay, I will make sure that I type, because there are wonderful questions. And I'm sorry about the technical difficulties. I wish I could have got to them.
Yes, and we will get to those questions. Don't worry. We have a wonderful post webinar wrap up, and those questions will be answered. We continue this in our meeting place, so we'll make sure that those do not go unanswered. And thank you so much for your efforts today, Eliana, Dr. Castillo. We greatly appreciate you taking the time to participate and join us for this webinar. And I will give the audience a big thank you for joining us and engaging with us today, sharing those questions. You're welcome to join us for future webinars, which we've listed up on the screen. If any of you have colleagues that were unable to attend the presentation today and you'd like to have them watch it, we have a recording on our N4 website. And obviously there will be some resources that will be shared post-webinar. And following today's webinar, we will share a survey with you. We appreciate you taking the time to complete that as we use the answers to help guide future topics for our webinars, and also sharing with you N4's mobile app. It's available on Apple and Android. And thank you again. We hope you're going to join us for future webinars. And I will hand it back to Dr. Castillo for her last words before we sign off today.
Thank you so much, Colleen. So thank you for attending. Thank you for the wonderful questions. I saw that a few of them pertain to, do we know how have other jurisdictions improved access to RSV prevention for newcomer communities? And the question is, the data is very limited. All we know is that what has worked is to make it available to every single baby. And that has required a lot of political will from specific jurisdictions.
And leaps and bounds improvements hopefully coming. We look forward to hearing more from you, Dr. Castillo. It sounds like we might have to have another webinar to continue this discussion. And I do also want to say a thank you to Marcia Bruce, who's behind the scenes, who is supporting Dr. Castillo today and was going to jump in at a moment's notice should we need her. So big thank you there. And we look forward to future collaborations. And thank you again to our attendees, and we will see you at our next webinar, which will take place on February 6th. Thank you again.